Welcome, everyone. Thank you guys for joining us for our summer 2025 webinar. And today we have Elise, who is a certified child life specialist, and she will be presenting an amazing talk about sensory support. So, Elise, I will let you take it away.
Great, thank you. Let me share my screen here. Turn off my video. Hello, everyone. Welcome. So today we're talking about sensory informed care. So meeting the needs of children with sensory processing differences in the hospital. So what are we talking about today? Sorry, let me move that out of the way so you can see all the slides. Today we're going to talk about a couple things. We're going to talk about what are the 8 senses. So we'll talk about the 5 ones that you've always heard of, and then there's a couple hidden senses that we don't always remember to discuss. So we'll talk about what those are and what those look like. And we'll talk about what are sensory processing differences, kind of breaks down into a couple different categories. So we'll talk about those different diagnoses and how it might impact a patient's hospital experience. And then we'll talk about strategies. Some bigger strategies like sensory rooms, but then also kind of DIY and different other ways and smaller ways that you can meet a patient's sensory needs to make those hospital visits as easy as possible. So what are the senses? You've probably heard of these before. You've got your olfactory, so your sense of smell, vision, sense of sight, tactile, sense of touch, auditory, sense of sound, and gustatory, right? The sense of taste. So these are the ones we typically talk about, especially as kids are growing up and we're learning about the different senses. But there's 3 other senses that our body has. And these are sometimes called the hidden senses. So you've got vestibular, proprioceptive, and interoceptive. So we'll kind of dive in. What are those hidden senses? So vestibular, we get those sensations through our inner ear, and it's a lot of balance and kind of the movement of our head through space. So it's our body's understanding of where is our head in relation to the surface of the earth? Are we upright? Are we standing on the ground? And we get those sensations through the inner ear to kind of figure out where our body is. Proprioceptive is also about the body, but body awareness. So an understanding of where our body parts are relative to each other. So through sensations that come through our muscles, our joints, and our ligaments, our brain receives information about where are our arms and our legs and what is happening to those body parts. And then interoceptive. So this is kind of the inside, the sensations that are happening inside your body. So recognizing that discomfort in your belly, is that you need to use the bathroom? Is it that you need to get something to eat and you're hungry? So interoceptive is understanding those sensations and being able to connect those with what is that sensation that I'm having in my body and what do I need to do about it? So if a child is struggling with interoceptive, they might not recognize they maybe need to use the bathroom. So they feel that pressure on their bladder, but if they're not able to connect it with their brain, they don't know how to solve that sensation. So those are kind of those 3 hidden senses. What does it look like when we're using our senses? So when everything's working great, how does it happen? So we get input, we get neurological process, receiving information, something comes in through our senses. So let's say we're in the office and we hear a noise. So we hear that noise through our ears, we receive that sensory input. Then our brain organizes and figures out how it's going to respond. Okay, I'm hearing a noise. Is it my coworker or is it a bear? I'm trying to process, am I in the office? Am I in the woods? This noise, like, how do I react? What should I do with this noise? And then output, the body responds. So you go, oh, I'm in my office. It's 8:30. My coworker's supposed to be coming in. I'm going to say hello instead of run away thinking it's a bear. So the body responds to whatever that sensory input is. So spitting out gross tasting food, running away from scary sounds. So when everything works, these so what happens when it doesn't work? When we can't process? I'm going to try to show this video. Hopefully it works. It's always hard showing videos in a presentation. But this is, I will warn you, bright lights and it gets a little loud, but it shows what happens when our body cannot process all the sensory input. So we're taking all of this information, we're trying to use it through our neurological processes, but we can't process everything and filter everything.
I don't know if there's supposed to be audio, but I can't hear anything.
You said the audio is not working.
Maybe the volume.
Let's see. I'm using headphones, so I'm wondering if that's what it is. So let me take off the headphones and let's try it that way.
Yeah, still no audio.
Oh,
I'm happy to see if you can share the link, I can probably play it through my end.
no. Oh, okay. Yeah, let's do that then. Thank you. I love showing videos because it's such a great visual, but I
Yes.
always have issues trying to show them.
Technology is great until it kind of stops.
Yes, very much.
All right, so let me share my screen really quick. Um, can everyone hear that okay? Okay. Oh, people still can't hear that. That's so strange. Um, well, I guess no one can
It's
hear it,
okay.
so I think
That's okay.
it's okay. But the link is
Yeah.
there. Please do view it. I think this is a great
Yeah.
video.
Yeah, I can kind of talk through what the video. So the video goes over a young boy walking through the mall. And when I go through the mall, I have a mission. I'm going to Bath and Body Works. I'm going to get the candle sale, and I go straight. I don't hear the person slurping their soda. I don't hear the coins dropping. I don't see the lights flickering, right? I'm on a mission. I want those 3 wick candles that are on sale. For kids who, or anyone, individuals who aren't processing that sensory input and are getting overwhelmed, they hear and see everything. So in this video, highly recommend watching at a later point. But the little boy is walking through the mall and he hears every coin that gets dropped, every slurp of a soda, every light flickering, every clicking of someone's heels walking by. And so towards the end of the video, he's so overwhelmed that he has a meltdown, right? And so it kind of then zooms out to other people watching, and in their minds they're going, "Oh, he's just naughty. He's just having a behavioral outburst," not realizing all the things that he went through leading up to it, all the sensory processing that he struggled with, and all the overwhelmed feelings that he was feeling before he got to that point. Okay. So our normal sensory processing is that neurological process, organizing the information we take in from our bodies and the world around us and using it in our life. What happens when we can't do that? What happens when we're struggling to do that and we're not able to process? That is sensory processing differences. So there's a lot of different terms: sensory processing disorder, sensory processing delay, difficulties, dysfunction. People use different words to define this. Carol Kranowitz, who wrote Out of Sync Child, a really instrumental text on sensory processing, calls it differences because it indicates that each person processes sensations in a unique way. So I tend to use the word differences, but if you heard sensory processing disorder, delay, difficulties, dysfunction, any of those other things, we're talking about the same thing. So a real brief definition of sensory processing differences, according to Carol Kranowitz, is problems in receiving, integrating, and using information obtained from the senses. So we talked about when our senses work, we get information, we process what is that information, what are the other factors around that information, and then how do I respond? Is it my coworker or is it a bear in the office? So the other thing to remember with this is neurological. Just like I mentioned with the video, right? At the end, he has a behavioral outburst. Everyone thinks he's naughty, not realizing all the things that happen to lead up to that behavioral outburst. With sensory processing differences, it's neurological. It's an inability to process the sensory input. It's a struggle with the sensory input. It's not parental. It's not behavioral. It's not just lazy parenting, someone didn't discipline type thing, right? This is something where kids are not able to process it And neurologically, they therefore cannot function when they are feeling overwhelmed and stuff like that. So we kind of talked about that, right? It's when we're not able to process this information. So how often does this happen? How common is this? How many patients might we see that have sensory processing differences? So there are a lot of different statistics. We'll kind of briefly go through them. So it's estimated that 1 in 16 children have sensory processing differences. So if you think about like classroom, chances are at least one of them, two, depending on the size of the classroom, have some sensory processing differences. 95% of children with autism also have sensory processing differences. So we know that our autistic patients are at a higher risk for hospital encounters for a variety of reasons. And so they are very likely to have sensory processing differences along with their autism. It's also estimated that 40% of children with ADHD have sensory processing differences. In a study looking at trauma scores, they found higher childhood trauma scores were correlated with more difficulty with sensory processing. And then in another study, 97% of patients with cerebral palsy reported at least one bothersome sensory symptom. So at least some degree of struggling with sensory input. And then other risk factors include prematurity, things like fetal alcohol syndrome, Fragile X, CHARGE, Angelman, some of those other more chronic conditions. So when we look at this, this is a lot of our patients. This is a lot of the children that we are going to encounter. Even if they don't have a diagnosis of autism or a diagnosis of sensory processing, but they have ADHD, we know that puts them at higher risk of having sensory processing differences. They have childhood trauma scores, higher ACEs, we know that puts them at risk of more sensory processing difficulties. BP, prematurity, a lot of our patients in the hospital, as you see more chronic kids, a lot of them have prematurity. That's why they're in the hospital, because of their history of prematurity. That's why they're coming back for follow-ups. And they're at a higher risk of having sensory processing differences. So what are the different types? How do we break this down into kind of different areas? So one of the types of sensory processing differences is sensory modulation disorder. This kind of breaks into three different categories. You have over responsivity. So that's a very low threshold for sensations. This is the kid who's avoiding stuff. So covering their ears, squinting, hiding from bright lights. They're very quickly overwhelmed. So it takes only a little bit of sensory input to be too much for them. A lot of times kids with this will struggle with transitions and unexpected changes because they're easily overwhelmed. Sensory under-responsivity is the opposite. So having that higher threshold for sensation. They may not realize when they're getting that sensory input. So kind of signs are bumping into desks and people, struggling to read or understand people's body language and facial expressions, a lot of times injuring themselves because they don't realize that something's hot or sharp. So a really good example is if a kid were to put their hand on a stove. If they have a high threshold for sensations, their brain is not going to realize that they're burning their hand until they have an injury on their hand, right? If you're sensory over responsivity, as soon as you feel a little warmth, you're going to pull your hand off. Great, no injury to the skin. If you don't feel that, if you need so much more sensory input to recognize that you're getting the input, then you're at a higher risk for injuries because you don't know when to stop. And then the third kind of category under sensory modulation disorder is sensory seeking or craving. So these are the kids that cannot get enough sensory input, cannot get enough stimuli. So a lot of times they like that big movement, the running, the climbing, the pushing, multiple stimuli. I've had a couple kids who have two iPads, two shows on each iPad, a lot of pushing and pulling. Some of the work that kind of helps calm the body when they're sensory seeking is like pushing a chair and pulling to get those big motor movements to calm the body. So when we talk about sensory, right, typically those are kind of the three things that we break it down into, and those are the categories. A lot of the kids that you see, a lot of the kids who are struggling to cope in the hospital will have some degree of sensory modulation disorder. But there are two other categories of sensory processing differences. There's also motor disorder. So dyspraxia has to do with coordination. So an inability to organize the body to move, information struggles to get from the brain to the body. So coordinated tasks like skipping and jumping are really hard if you can't tell your body how to move your brain in this, you can't tell your brain how to move your body in this coordinated way. And then postural disorder. So Carol Kranowitz calls kids with sensory-based motor disorder and postural disorder the sensory slumper because they tend to have low muscle tone, poor coordination, have trouble stabilizing their own body. So things like it's hard to turn door handles or knobs that need pressure, balancing during biking where you're trying to hold your body up while you're pushing the pedals, um, or kids just might tire easily if they have that low muscle tone. And then sensory discrimination disorder. So with this one, the central nervous system is inaccurately processing the sensations. So it can lead to not being able to use the sensory information to function. So maybe the child has difficulty processing sensations of pain. They may not recognize the differences between different sounds. They may feel faint, but not be able to connect that they're hungry, and that's why they're feeling faint. So you're getting the sensations, you just can't process and respond accordingly. So I love this water visual to kind of show those differences. So we have our neurotypical individual, hypersensitive, and then hyposensitive. So if we imagine a water glass, you pour a certain amount of water, fills a neurotypical individual's cup. They receive the sensory input, fills their cup, they can manage it, they're not overwhelmed, but they're not like underwhelmed. They're doing okay with that sensory input. For an individual who's hypersensitive, it's a small cup. So we give them that same amount of water, it's overflowing, it's overwhelming, it's stressful. So if you think about walking through a mall, if you are not overwhelmed by sensory input very much, maybe you're just filling your cup and you just kind of reach right to the top, get through the mall fine, it's all good. If you're hypersensitive, you receive that same input as a neurotypical person, but it's too much real fast and it overwhelms your cup. If you're hyposensitive, so this is those sensory under responsive kiddos, the sensory seeking kiddos, you need a lot. So the same amount of water that overwhelms the hypersensitive individual, the same amount of water that is just right for a neurotypical individual is not enough sensory input. And to calm and regulate your body, you need so much more sensory input, or in this visual, more water. So we'll just skip over the video for this one. But this is another great one I'd recommend. It's about sensory overload in the hospital. And similar to the video of the little boy walking through the mall, this patient comes into the hospital and the nurse starts doing a lot of stuff. She's taking his vitals, she's setting up for a blood draw, but there's no communication. So in his mind, he's watching everything happen and he's hearing the lights flicker and she's crunching as she's opening up wrappers and she's putting a pillow under his arm and he doesn't understand why it's happening. So he gets more and more stressed because he doesn't understand. And then all of a sudden, it's too much and he shuts down. And the nurses kind of got this confused look like, oh, how did we get here? Like he seemed cooperative and fine. But again, it's that sensory overload, that overwhelming feeling where he was feeling calm when he walked in. Those little things built up and then it became too much.
Can you share the link, Elise, in the chat?
Yes. Yes, I will do that right now. Let me grab that link for you all. Perfect. So yeah, I would definitely recommend looking at that video too. So how do we, so why does it matter? Why does it matter? Oops, sorry. That we talk about these things, that we talk about that sensory experiences in the hospital. Because as I kind of mentioned earlier, our autistic kiddos or kiddos with sensory processing differences, kind of both of those categories, are at increased risk of medical contact. So they have higher risk of eye conditions. So it's believed that the prevalence of ophthalmologic disorders is 3.5 in typically developing children and 13.5% in children with autism. We know 95% of children with autism have sensory processing differences. So kids with autism, they need glasses, they need eye muscle surgery. There's a lot of dental visits. So another study found that children with autism had significantly more decayed, missing, or filled teeth than their neurotypical peers. And 95% of autistic children had gingivitis. We also know dental visits are so overwhelming on the sensory end that a lot of those kids need sedation to get through those visits. And then kids with autism or sensory processing differences are also at a higher risk of GI conditions. So one study found that the prevalence of GI symptoms in autistic patients range from 0 to 69%, with kind of a general prevalence, about 33% higher than the general pediatric population. Sensory processing differences also leads to higher risk of constipation because a lot of times it leads to withholding behavior. So if you're uncomfortable with sensory sensations, going poop is a very uncomfortable sensation for a lot of kids. So as it gets worse, as they withhold and leads to more constipation, they're going to need more GI visits, GI procedures. So we know that our kids with sensory processing differences are coming to the hospital at a higher rate and more often than their neurotypical peers. So what do we do? How do we support these kids? So I like to break it down into kind of three main categories: assessment, adaptive sensory environments, and then visual supports. So key to be a child life specialist, key to working with any child, right? Any encounter is to assess, what do you need to do to help this child? So there's different ways to do it. Identifying those sensory needs is huge. So we talked about how sensory processing differences breaks down into those different categories. So is the child sensory seeking or are they sensory avoiding? Because that's going to change your intervention. If they're sensory avoiding, lights down, fewer people in the room, weighted blankets, quieter area. If they're sensory seeking, bring in the light up toys, bring in the singing toys, bring in the vibrating seat cushions, right? Like we need to meet them where they're at and give them that increased sensory input. So along with that, as you talk through with caregivers and identify, is the child sensory seeking or sensory avoiding, what kind of input calms their body? Do we need to add more or do we need to take away sensory input so that they can self-regulate and be able to process the already stressful situation of the hospital? Because we know hospitals are stressful, even for neurotypical kids. There's pokes, there's new faces, there's doctors, there's exams, there's big medical words. It's a scary experience. And so if every child, right, our neurotypical patients are dealing with all that, and then for our kids with sensory processing differences, you put on the sensory input of the lights of the hospital and the many people and the beeping of the machines and everything else. It's really important we learn, how do we help these patients regulate? How do we help them calm? And then creating an individualized plan of care. So caregivers are the experts on children. They know what works, they know what helps. So use those caregivers to identify what kind of support is best for the child. Use their knowledge and expertise. Sometimes caregivers have been in the hospital a lot with their children and they know what works. So then you just say, hey, what helps in the hospital? Copy and paste. Sometimes kids haven't been in the hospital yet. And the caregiver might be like, haven't been to the doctors, haven't been to the ER, haven't been admitted, not quite sure. So the other thing that I'll often ask is, what's helpful at home or school? So what do you do at home when your child needs to regulate and is overwhelmed and stressed? What do you do at school when there's a test or a presentation or a group event where your child is stressed and overwhelmed? Because a lot of times we can kind of modify or copy those interventions. We can do something similar. If you tell me for the group events at school, when it's a big get together, your child sits in a separately area where they can still participate, but it's further away from like where the microphones and the speakers are. Okay, well, we can do that. We can make a quieter area. We can put you further away from the crying babies in the recovery room. We can kind of make those adaptations. So if the caregiver you're talking to doesn't know what to do to help in the hospital, a great question can just be like, what do you do other places? So I love to show this health passport from the UK, the National Autistic Society, because it basically is that assessment piece, right? It's identifying what kind of support does an individual need. And this is designed for an autistic person, but could be used for anybody with sensory processing differences. So it goes over, how do I communicate, right? How do I want to talk to you? How do I want you to talk to me? What helps? What kind of things cause me distress? Is it needles? Is it blood pressure? Because that one gets really hard for a lot of our patients, right? Is it just the bright lights? I can handle the pokes if you dim the lights. So what kind of things cause that individual's distress? How do they experience pain? How do they communicate pain, right? Behaviors are communication. So we want to know, how does that individual communicate pain? Do they shut down? Do they cry? Do they yell? Do they maybe escalate and engage in self-injurious or aggressive behaviors? Because that's communication. not being bad, it's not misbehaved. That is an individual saying, something is wrong. I'm trying to tell you something, but I don't have the words to do that, which is why it's so important that we identify with our patients or caregivers, whoever we're able to work with, what is that communication? How are you telling us when you're distressed or in pain? So this is a free resource available online. It's the website right there, autism.org.uk/health passport. You can also just Google autistic health passport or National Autistic Society. So a lot of times this is a great resource. At our facility, we have built into our Epic, our electronic medical records, a coping plan. So our kiddos who have any kind of diagnosis, autism, developmental delay, cerebral palsy, sensory processing differences, even just like high medical anxiety, trouble coping, behavioral concerns, we're able to make a coping plan to communicate with the staff, who is this child? What are those diagnoses? What are those triggers? So in this example, you can see transitions are hard, babies crying, and non-verbal demands. The baby's crying, that is an easy fix, right? When kids are coming in, we have a bunch of different rooms. We can, most of the time, make a choice and say, oh, well, I'll put you down the hallway further from the 1-year-old because I'm expecting the 1-year-old to cry. I'll put you with the teenagers down here. I'm not expecting them to cry as loudly and hopefully not disturb you. Transitions, if transitions are a trigger, do we need to move through lots of different rooms? So I know some facilities, right? You come back, you get called to the vitals room, take your vitals, then you go see the doctor, and then you go check out in another area. So if the trigger is transition, how can we change that? Can we bring the vitals machine into the clinic room and do all of it there and then get rid of the transitions and get that out of the way? So that's why it's so important to identify those triggers so we can adapt that care as we need to. We kind of talked about how do they communicate, what do they do when they're distressed, how to comfort them. Some kids, distraction is great, right? Give them their favorite toys. On, perfect. Other kids need space, right? If they need to kind of self-regulate and calm themselves down in a low stim area, maybe distraction with the light spinner isn't going to be helpful, and that isn't best. So it helps to identify before a kid escalates, what do we do? When they start to get distressed, do we just back away and create that quiet area, give them some space, or do we stay there? We also like to talk about if the procedure isn't going well, what do we do? Some kids do better with a break and they can do better a second time. Other kids, they'll never recover. You need to get it done and then let them calm down after. So we identify that with the caregiver. Environmental things, quiet area, lights down low, moving things around in the room. I've had some patients where a bed is the trigger. So that's our environmental accommodation as we pull a bed out of the room. You'd be surprised, a lot of times you don't actually need a bed in the room. You can save it to the last minute when you're doing a procedure or sedating a child or something like that. Talking about pokes, because that's the most common procedure we encounter. Interests, that helps to know. I once had a patient who loved picking at carpet squares, and that's not something that's normally in my distraction bag. So making sure to put that, identify what those things are. And I noticed a question someone asked about the hospital uses Epic. So I did want to point out there is an Epic library. So if you go online to Epic, you can access the library and basically like see how every other hospital that uses Epic uses their charts or uses like different flow sheets and builds in there. And so you're able to look up coping plan and you should be able to find this. I also have my contact information at the end of the PowerPoint. So you can also send me an email directly and I can get you that link to the library. But Epic is really cool because it uses this library where you can see how everybody else does their Epic, which can be really helpful. And so then we also talk about communication. So what does that language look like? Verbal, nonverbal, somewhere in the middle. How do they communicate? How do they also receive, right? Because we know nonverbal does not mean non-understanding. So just because they use pointing and gesturing or a communication device to tell you something doesn't mean they don't understand the words that you're telling them. So identifying how much does the child understand? And then obviously, what are those sensory sensitivities? What can we do to make that easier with those sensitivities? So I kind of touched upon them, kind of showed that coping plan. But just some basic questions, right? Assessment questions when you meet a family, meet a caregiver, you're talking through stuff. First thing that I always ask is, what are those triggers? Because the only way you can avoid them is if you know them. So what are those triggers or things that easily upset the child? We mentioned communication. How do they communicate? How do they understand? Identifying the expressive versus receptive language. When the child's upset, how do they express it? Behaviors are communication. I cannot say it enough. Behaviors are communication. I'm not saying I like when a child punches me to tell me I need space, you're overwhelming me, and I'm stressed, but they're communicating with me. So I want to know ahead of time though, because if they communicate with a push, then I'm going to give them more space when we're doing hard, stressful things. So, how does the child communicate when they're upset? What do we do once they get upset? What is the solution? How do we help calm them? How do we help de-stim them? How do we help them regulate when they're starting to get upset? Sensory sensitivities, right? Are they seeking versus avoiding? Are they sensitive to noise, light, touch, taste, smell? I think taste sometimes gets forgotten in the hospital, but that's still really important, especially if you're like in surgery where you need to drink juice or eat a popsicle after, or if you're in an inpatient unit where you're going to try to get them to eat and drink post a procedure. It does help to know, do they have sensory sensitivities with oral intake? And how can we make that easier? Is there certain textures they like, don't like, certain drinks that we can help with that? And then environmental accommodations. So what can we do? Can we quiet the area, dim the lights, pull the hospital bed out? Sometimes it's just rearranging the room. So I've had some kids where I pull all the chairs out because they really like that big movement. They want to jump, they want to run, they want to rock. And if the clinic room is tiny, you run out of space. So sometimes a simple solution can be, well, let's pull the chairs out of the room, maybe one chair for the doctor, maybe one for her caregiver, but then pull everything else out and just give them space. Or we'll use like a larger room to give them a little more space to move around. So what are environmental accommodations can we do? So that's the first step, assessment. Who is the kid? What are we doing? How are we going to help them through? One of my favorite interventions is adaptive sensory environments or sensory rooms. So these were first developed in the 1970s by Dutch therapists, and they created a multi-sensory tent for individuals with learning difficulties. And it was a space for individuals to interact with and enjoy sensory experiences. So what is that adaptive sensory environment? In short, it's a room with sensory items for the specific needs of the patient. So you can modify lights, sounds, and items as those multiple sensory stimuli are adapted for the child. And it creates a relaxing, safe space to de-escalate from that sensory overload, from feeling overwhelmed, anxious, or hyperactive. So I do have pictures of the rooms and we'll go into more detail. But first, do they work? Evidence-based, right? That is the core of our work as child life specialists, is that we provide evidence-based interventions. So same applies when we're using sensory rooms. Where is the evidence behind that? So research has found that having control has been associated with increased attention and reduced behaviors. So when they did a study on practitioners who worked in multi-sensory environments with children with autism, they found that that piece of control, adjusting the coloring of the lights, adjusting the items in the room, adjusting the projector, whatever it was, it helped with increased attention and reducing behaviors. In a study looking at virtual reality sensory rooms, they found even just creating that virtually through like VR goggles for individuals with developmental disabilities, there was a significant reduction in anxiety and depression and an improvement in how they were able to process sensory input, even just in that virtual environment. In the forensic mental health setting, sensory rooms were again found associated with decreased stress and improved patient experiences. And then in a psychiatric ICU, not only patients, but the staff as well found that sensory rooms were a really positive therapeutic tool. I always laugh because the sensory rooms are really helpful for the patients, but the parents and the staff love it too. Our nurses love having a patient in there because it's so zen, it's so calm, it's so relaxing. It's different than the hustle and bustle of the emergency department nurses station, right? Parents love it. It's zen for them too. So while we're talking about in this presentation, right, our children and our patients, there's benefits for everybody surrounding those children by having these sensory interventions and these adaptations to care. And then what about in the hospital, specifically in the hospital? A study that looked at adaptive care for patients with developmental disabilities. They interviewed families on their experiences and their interventions. And they found that modifying the environment and providing sensory materials were an effective non-pharmacological intervention in the pre-op setting. And then at our facility, we have also found using these sensory rooms has cut down on the need for Versed and other pre-meds before going back to surgery because our patients are at a much calmer level when they get there. But they don't get to escalate before going back to the OR because we've created this sensory environment for them. Multisensory devices on a study on positive healthcare encounters for children with autism and accommodations during surgical procedures found that multisensory devices, so I have some pictures later, but think like if you've ever heard of a Vecta or a sensory rover that has the bubbles and the projector and the mirrors and the fiber optic strands, those multisensory devices were used as distraction and decreased anxiety in that pre-op setting. And then dental. So honestly, dental is one of those areas that has done a lot of research on sensory adaptive environments because, as we mentioned, our kiddos with autism are at a higher risk of needing dental things, whether that is sensory aversion to brushing their teeth, whether it has to do with the diet due to oral sensitivities, whatever the case may be. They need dental visits, and it's really hard to get through dental visits. So there's been a lot of research, and they found doing sensory adaptive environments helps coping in not only the patient's developmental disabilities, but the typically developing patients. So if you have a sensory room and you have no one with autism on the schedule that day, it doesn't matter. It still helps those typically developing patients as well as stay calm and cope in the hospital setting. Those adaptive environments reduce pain, reduce sensory discomfort, behavioral distress, and physiological distress for kids during their dental visits. And it was an important factor in influencing the successful outcome of those dental visits. So some of the dental interventions that they used were dimming the lights, a lot of weighted blankets and deep pressure, and then sensory toys. So we've talked about, does it work? Kind of that research behind it. What does it look like? So these are some pictures from our sensory rooms. So we have sensory environments, dedicated sensory rooms in our perioperative setting and in our laboratory. And then in our outpatient like clinic areas, we have what I call like DIY sensory rooms. So different features in these rooms. You'll notice in the lower left, there's no bed. So again, if that bed is a trigger, we get the bed out in pre-op. We really don't need it until the kid's getting sedated in the OR. So we'll put the bed in the hallway. They won't get on the bed till maybe after a pre-med, maybe they'll just walk back and just go straight to the OR bed and skip the pre-op bed. But it's meeting where the child's at, giving them a safe mat on the floor, space to move around, space to get sensory input with those textured discs and the peanut ball, and moving the thing that's so scary. Or maybe it's the floor tiles. Those are a huge hit with getting kids into the hospital. We have different seats for them to sit on that aren't a hospital chair, headphones, marble walls, kind of lots of different things to touch and feel. The other intervention I love, if you can't or don't want to remove the bed, in that lower right, the bed is turned sideways. This is one of my favorite interventions because if you turn a bed sideways against the wall, it looks like a couch. And suddenly it is not as scary or as threatening for our patients. So we have 3 different sensory rooms in pre-op, and one of them, the bed is always turned sideways because it opens up the room, it gives you space to walk around, but it also takes away the scariness of the bed and turns it into a couch. And I've had multiple patients sit on a bed who typically don't sit on a hospital bed, but in that room, it's a couch because it's sideways. So you can sit on it and it's much less threatening. So sometimes that care can be as simple as adapting the room, rearranging that furniture, putting a few things into the room. And then we have our sensory room and lab. It's very hard to take pictures because we have dim lights in the room. So I apologize for the pinkish hues there. But different features in this room. One thing I love is that chair. The chair is extra wide, so you can actually have 2 adults sit next to each other. So if it is a teenager who needs it, who wants a parent to sit with them, in your typical lab draw chair, when you're 16, you usually can't fit on parent's lap, right? At a certain point, you can't fit on the lap very well. So this is great because we can still use a comfort hold. We can still have caregivers sit with the child, but they both fit now. We've got a floor mat. So if the chair is the trigger, if the bed is the trigger and we can't get up anywhere, we can do a lab draw sitting on the floor. And then in the bottom right, we have that light, which I like to call out So that's almost like a spotlight. So that allows us to keep the lights dimmed in the room, but also have a spotlight on where we're doing the blood draw. Because obviously we want the phlebotomist to see what they're doing. We don't want them to poke a bunch of times. We're trying to balance between what this child needs to stay calm and stay regulated, but also the medical care we need to provide. If we need to do a blood draw, we have to place a tourniquet, we have to see the vein, we have to poke, right? That's the process of the blood draw. So that spotlight really helps us see better what is going on in the arm, but then it doesn't overwhelm the child because we're not turning on all the lights. We're just putting a light on the AC or the hand wherever we're doing that poke. And then we also have like weighted blankets and a bunch of different sensory toys in this room as well that we can use to distract and calm. Um, and this room is nice because it is so big, is it can be used to de-escalate after the blood draw. So if we do the blood draw, it's hard, kids are upset, valid, blood draws are really rough, they're not fun. Um, this space can be used to de-escalate. It's a little further away from our lab. It's not in that rotation of our lab draw rooms, so it doesn't hold up the rest of the patients as much. And you can just give them space. You can use that floor mat again, create a safe space to kind of back away and let them calm. And with all the sensory items in the room, it a lot of times helps them de-escalate faster than if they were just in a regular hospital environment. And then our outpatient clinics. So at our facility, a couple of our rooms have like that marble wall or the light panels that you'll see in the center. But most of the rooms are DIY sensory rooms, which means I bring a bunch of sensory stuff with me. The projectors and the gel floor tiles are a really easy way to change your room as you bring them in, kind of dimming the lights, putting the projector on the ceiling, gel floor tiles on the floor to kind of engage them walking in. And then obviously a lot of like smaller sensory toys and fidgets. A lot of times we'll bring in like weighted blankets are helpful. We have these like gel lap pads that are weighted, but you can also push on to get sensory input, and those are really popular. Vibrating seat cushions. I've had a lot of success. They're on Amazon. You can get this vibrating seat cushion that when you sit on it, it provides sensory input. And it has done wonders for our kids with ADHD or our kids who are very active who struggle to sit for an exam because you can be flexible to a point, but at a certain point, a provider needs to look at you, right? So, especially with eye exams, we found it was really hard. The doctor can't look at your eyes if you don't sit still, but also you need to keep moving to get your sensory input, which is totally valid. So, we had a lot of success using vibrating seat cushions to kind of meet patients in the middle and give them that sensory input while keeping them still. So, in outpatient clinics, it's a lot of just kind of DIYing, bringing different items in. And I love to show this because not every facility can have dedicated sensory rooms. I wish they could. I wish we had them everywhere in our hospital, but budgets are real. Space is tight in every hospital. So a lot of times doing DIY, just having a few things in a closet you can pull into a room for the kids that need it can make all the difference. And then I just wanted to show some of my favorite sensory items. There's so many on the market. Everyone's going to have their favorite. Again, use that assessment, talk to the kids, figure out what they love. But some of the things I love is we have sensory brushes that are really nice to provide that gentle sensory input. Pop tubes. I love this toy with all the cords because it gives a lot of sensory input when you're pulling. So for the kids who are looking for it, it takes a bit of pressure to pull. Similar to the monkey noodles, kind of takes some pressure to pull. Chewy is great if they're oral sensory seeking and looking for that sensory input there. And then weighted blankets as well are really helpful. So these are some of my favorites, but obviously there's a bazillion different things out there on the market. But what I like about these is that they're smaller and easier to carry around. So this, if you are tight on space, these don't take as much space. And they're not as costly as maybe getting a Sensory Rover or Vecta for one of your rooms. So I also want to talk about adapting the environment in any setting, those tiny little interventions. So in that picture, you can see we have a part with the fiber optic strands, gel floor tiles. This was done for a patient who struggles with all doctor visits. Just being in the hospital is hard. Being in that medical setting is hard. So we made it less medical. We put them in the biggest room we had, gave them lots of sensory input by climbing and stepping on things, and they did so much better because suddenly it didn't look like a doctor visit. And the two pictures on the right, those are from our ophthalmology clinic. So in healthcare, there are always some non-negotiables, right? To get a visit done, to do a procedure, to do an exam, we have to do certain things. For an eye exam, you have to be X amount of distance from the visual acuity chart. If you're not, then we don't know what your visual acuity, we don't know what you can see. Being back by the chair is a non-negotiable. Now, the negotiable thing is the chair. If the chair is too scary, too triggering, you can see that middle picture, we skipped the chair, put some gel floor tiles down where she needed to stand. Suddenly she did great with the exams. In that chair on the right, I moved the exam chair over and we put a regular chair. I had a patient who I'd called ahead of time, done my assessment. Family said, will not sit in a chair. That is a huge trigger. Will not sit on a bed. Will not sit in an exam chair. Will not. That is the biggest trigger. Okay. So we got rid of the exam chair, moved it over, put that orange parent chair that matched like the other chair in the room that mom sat in. And as soon as the patient came in, she sat right on that orange chair, did her whole exam in that chair. She was in the perfect spot for the doctor to look with the flashlights. She was in the perfect distance for visual acuity. We got everything we needed, but we also met her where she was at. The chair was the trigger, so we got rid of the chair. So one of my favorite sayings I like to say is pick your battles. So think about what really has to happen. An example in ophthalmology, distance from the TV has to happen. Chair doesn't have to happen. So as you're working with these patients, as you're trying to figure out how do we get through the visit, there will be things in the hospital that you need. There will be things that the medical team needs to do to help the child, but pick your battles. Do we need to fight about sitting in the chair? Maybe not. Maybe we just need to be near the chair and then we can meet them where they're at and kind of adapt that care. So last thing we talked about, interventions. How do we support patients? We assess, we do sensory support, and then visual support. Visual support is huge because it helps with that predictability to know what's happening. So kind of some common visual supports are preparation books, videos, and visual schedules. So visual schedule is on the right in that orange folder, and it's a helpful breakdown of what are the steps. So not only telling, right? But if I tell you all the steps, that can be really overwhelming and a lot of information to hear. So it's a visual of what do we need to do. Some of them might be unpleasant. There might be a bright light with a flashlight that you don't like. But this is how many steps we're going to do. We can put them in the all done folder when we're done and kind of see that process as we're moving. In that picture on the bottom left with the different providers' faces, that was for one of our multidisciplinary clinics where they were meeting a bunch of people. So that's scary, that's overwhelming. But to be honest, most of the people were just talking. Most of the people are just talking to the family. So we use the schedule for this patient to break down each person they're going to meet and what are they doing. So when the nurse comes in, she's just talking and checking you into the room. The GI provider, they're going to do a physical exam plus talk. Psychology, though, they're just talking again. Physical therapists, they're going to do a bit of an exam. Nutrition, they're just talking. So kind of breaking down each person that is coming in and what are they going to do to give that predictability so the child knows what to expect. So I just want to make sure we're good on time here. So the last thing I kind of wanted to talk through is there was a research study or article written by Mary Doherty, Sue McCowan, and Sebastian C.K. Shaw that was published in the British Journal of Hospital Medicine. And they use the SPACE framework to talk about support for patients with autism, but applies also right to our kiddos with sensory processing differences. And this framework was designed to facilitate equitable clinic care for autistic individuals. And I love the way they break it down. They break it down to sensory needs, right? So we talked about recognizing what are those sensory inputs? How do we adapt them? Predictability. How do we make that visit predictable? Preparation books, visual schedules, all those different supports so they know what to expect with the visit so they're not shocked when someone comes in to touch them for the physical exam. Acceptance, communication, right? Acceptance, recognizing behaviors are communication. Kids are going to act differently, individuals act differently. That's not a good or bad thing. That is how they are, and that is okay. Communication, communicating with the patient, making sure we're understanding them. And then empathy, right? Just meeting those individuals where they're at and what they need. So I put this visual here because I think this is such a helpful small tips, right? If you look at the things they're recommending, some of these are really easy. Turning down the lights, giving sunglasses. That's small. That's something we can often do. Avoiding conversations in the noisy environment. A huge intervention for sound sometimes is waiting your turn, one provider at a time. So yes, maybe some visits, it's typical that 3 people come in because that seems faster and better for the family. But if the child is struggling with too many people, then maybe that's what the family wants is, okay, well, we'll stay longer, but we'll meet one provider at a time so we're not as overwhelmed. Smell, right? Thinking about those cleaning products. Obviously, we have to clean in the hospital. That's a non-negotiable. But can we leave the door open for a little bit before we bring the patient back if that's going to be a trigger or something hard for them? Talked about taste a little bit more. Touch, right? Some touch will have to happen. If there is a doctor that needs to listen with a stethoscope, they will have to put the stethoscope on the child, right? If they need to examine the belly, they will have to touch. But avoiding casual touch, right? Recognizing, okay, if they're sensitive to touch, I'm not going to pat their head or rub their back when I say hello, right? I'm going to recognize they don't want that touch. So we'll wait till it's a really important touch that the doctor needs for the exam for the child's health. Thinking about temperature. And again, we talked about those kind of hidden senses, right? Proprioception. Is there a need for proprioceptive input? Should we give them things to bounce, to run, to push, to pull to get that input? Rearranging the furniture, right? If the kid is looking for that proprioceptive input, let them push the chair around. Who cares, right? Let them push the chair and rearrange the chair throughout the visit if that's what's regulating their body and calming them. And then interoception, recognizing that if someone is struggling with the interoception, right, they might not recognize what those sensations are saying. So questions about sensations might be hard to understand. So I love this framework because I just think it sets a really good stage for some of those cost-free, small, easy to do interventions. So how do you adapt care without additional resources? We kind of touched upon already, but simple things, dimming the lights, talking the family away from the patient. So a lot of times in pre-op, that's something we'll talk about before a visit, that we have a lot of providers, right? Before you go for surgery, people have to talk to the family, the surgeon, the anesthesiologist, the nurse. We have to so we can take the best care of the child. But if all that conversation, all that talking is overwhelming, well, can we take mom next door and leave dad or vice versa, right? Can we take one of the caregivers, go over that history, get those consents in a separate area from the child, and then leave somebody else with the child to make that easier? Condensing care. So this is a big one I always push. What is most important? So for our eye exams, the most important thing is that the ophthalmologist looks at the flashlight. For surgery, the most important thing is that anesthesia listens to the lungs to make sure they're clear for surgery. Now, typically, the nurse, the PCA, the tech who brings a kid back, they'll do those things. They'll look at the flashlight, they'll listen with the stethoscope, because we're doing all these things, checking off, making sure it's looking good before the provider. But if those things are triggers, then maybe the key is condensing care, recognizing, okay, you're coming for surgery, any kind of touch is a trigger. Stethoscope exams are hard for you. We know anesthesia has to listen. They're going to make the final call. They're going to decide if you're clear to get sedated. So can we skip the PCA, the nurse, and the nurse practitioner so we're not escalating you before that provider? For our eye exams, we know the ophthalmologist has to use the bright flashlight. They have to because it's their license on the line, right? It's their exam. They have to look at the kid's eyes with that. But do we need the tech to do it a couple times beforehand? Maybe not. Maybe that's what we skip and say, okay, you're starting to get escalated. The doctor has to look. So we'll skip the techs looking with the flashlights. Deep pressure squeezes. So we talked about weighted blankets, but if that's not a resource, squeezes on the shoulder, squeezes on the arm, squeezes on the hand, squeezes on the legs, right? A lot of times those rhythmic, methodical deep pressure squeezes can be really calming, especially if the kid benefits from deep pressure, but you don't have access to a weighted blanket or anything. X-ray lead is another great resource if you don't have weighted blankets. So I've many times used X-ray lead for a patient to kind of calm them if they need a weighted blanket and we didn't have access to one for whatever reason. Blankets to reduce light and noise. So again, if resources are limited, hospitals have blankets, right? So you can use that blanket to put over the head to cut down the noise. Maybe whatever setting you're in, you can't dim the lights. You don't have that option, but a blanket that they can cover their head with can get the light away from them while you're leaving the light for whoever else is in that environment. I talked about, right, sensory things. I really like Chewies for kids who are oral sensory seeking. If that's not a resource, a washcloth is another great thing that they can chew on. A little sturdier, a little bigger, kind of has some texture to it. So that can be used if your kid is orally sensory seeking and you're trying to find ways to give them that input. And then we talked about this a couple of times, but just moving the items in the room costs nothing to kind of redecorate and rearrange things. Or putting the patient in the hallway, picking a bigger versus a smaller room, quiet versus louder. Obviously, not everywhere has the different sizes of rooms, but if you have that option, a lot of times identifying which would be helpful. And then with that assessment piece, telling families to bring items. So if you don't have a lot of resources, especially, or even if you do, right? Calling those families ahead of time and encouraging them to bring what works for their child, because chances are they already have that. And then just getting creative. So crib projectors, right? From the infant units, those projectors can work in any room. And yes, we use them with the cribs to see the child, but maybe you can put them in the clinic room for some bright lights or some light sensory input. Larger chairs. So some patients want to sit with their feet off the floor. So do you have an extra wide chair that can be brought in so they can kind of curl up on the chair instead of sitting up? So I know we're kind of cutting it close to 7, but I did want to open it to see if anyone had any questions or anything that I could answer. I know that was a lot of information.
Thank you, Elise. That was very informative. I know I learned so much. I work a lot with autistic kids, and some of the stuff you shared, I'm like, this is great. So thank you for sharing that. I think we did have a question from Christine. She asked, what is best, real pictures or cartoon visuals?
So I think that depends on the kid. I think typically there's kind of two answers to this. So I think typically real pictures are best. But I'm also a realist. I worked in the hospital for many years. Sometimes those are really hard to get. And so I think cartoons are a good alternative, especially when you're struggling to find pictures of certain things. So if I have the choice, I would always try to do real. I've also done some prep books with the actual patient in it, right? We've kind of done some practice visits where I've gotten pictures of them doing the different things and putting it together for their book. So I think if you have the ability to do real, I think it's easier for kids to understand and kind of see themselves in it. But I also think there's a lot of value in cartoon pictures. And typically, I think those are more accessible. People, you have more ability to get them. It's an easier resource to make.
Right, and I feel like nowadays with AI, I'm sure it would be easy to create, cartoon visuals, but sometimes I'll plug in pictures, of my kids, and then AI will like formulate various visuals for you, which has been super cool.
Yeah, that's a great idea to use AI for that.
Do we have any other questions?
We'll put up my contact information. Oh, sorry, I guess references. Um, but there are my contact information. So feel free to reach out via email as well. If anyone has additional questions or things they want to talk through.
And I will be sending out a follow-up email, so please be on the lookout for that email, especially if you're interested in obtaining a PDU for attending today's webinar. Thank you so much. This was again super informative and yeah, great presentation.
Awesome. Thank you everybody for coming.
All right.